So for this lecture on pediatric swallowing, the objective is for you to understand what the speech-language pathologist's role is and how they approach working with young children. This video found here on YouTube, I'm going to show you sections of. It's really important that anytime you're working with disordered populations, you understand what normal is. So this little video here does an evaluation on a preemie. So a typical gestation age is 38 to 40 weeks, but this is a preterm infant born a couple weeks early. And so the nurses are walking you through what they do to assess the infant's health. And so we're going to follow along, and I'm going to stop the video at certain points to share with you certain things that I want you to notice about the baby. Okay, hold on one second here. There we go. Sorry about that.
Premature twins who are almost 24 hours old. The terminology late preterm infant was coined in 2005 and is defined as babies who are born between 34 weeks and 0 days gestational age to 36 weeks and 6 days gestational age. These infants are at increased risk of certain morbidities such as temperature instability, hypoglycemia, respiratory distress, immature regulation of breathing, hyperbilirubinemia, and feeding difficulties related to immaturity of their suck, swallow, and breathing coordination.
Now I'm stopping here to point out to you that all of these things that the narrator just said come together to allow an infant to have a safe and efficient swallow. And so when we work with premature or low birth weight babies, we are working with them for swallowing safety. The second part of the equation, though, is that we believe in Western cultures that babies learn language through interacting with their caregivers. And so feeding is one of the couple of routines that young children experience that give them the very first experience with turn taking. So our big concern is that the child is safe and that the child is getting adequate nutrition and hydration. But the secondary concern is that we're creating a situation in which the baby and the mother or the baby and the caregivers can bond during feeding and eating.
Our infant was initially on a radiant warmer, but demonstrated a stable temperature following birth, and now is swaddled in a crib. On general observation, you can see that the infant is lying in the supine position. She is pink.
Supine means on their back or on their spine. I do want you to notice the color is a really rosy, really pretty pink on this particular infant.
Breathing comfortably in room air and appears well. She is being monitored with a pulse oximeter on her right foot, EKG electrodes on her chest, and a temperature probe on her flank. The dried remnant of the umbilical cord can be seen with an umbilical clamp attached.
So one of the things that should start to become very clear is that as speech-language pathologists, if we're going to work in with preemies, with young babies on swallowing, we do have to make sure we have a shared understanding of medical terminology and medical procedures. Just like when we work with the regular education classroom teachers, we need to know what an IEP is, we need to understand how the school schedule works, we need to know that hierarchy, we need to understand the curriculum that the teachers are teaching and help teach that. And so the training differs to the extent that if I'm going to work with medically fragile patients across the lifespan, I need to also understand that setting. So this is one of the differences between a speech-language pathologist and a teacher, is that our speech-language pathology students have to train across settings. We don't train setting specific. Now, they do get courses to help them excel in educational context, but they also get courses to help them excel in medical context. But we have to understand swallowing disorders across the lifespan. We have to understand language disorders across the lifespan, and etc.
As you can see, she does not need a nasogastric tube for feeding.
A nasogastric tube is simply a tube that's inserted through the nose. It covers over the back of the palate, which you may recall from our speech disorders lecture, normal anatomy, and then it goes down to the stomach over the back of the palate. Nasogastric tubes can be left in place for 7 to 11 days. They're not really indicated for time much longer than that, but it's an alternative form of feeding that allows the infant to get adequate calories to continue neural and physical development.
There are no dysmorphic features. Examination of the oropharynx
That's a cutie.
reveals no clefts or other abnormalities. She is pink without evidence of central cyanosis or anemia. There are no birthmarks or other obvious skin lesions. The cardiovascular system is generally evaluated first, as the heart sounds are more difficult to hear if an infant is agitated and crying. Auscultate the heart after you have first noted the position of the apical impulse. Remember to specifically listen for the valve closing sounds S1 and S2, extra sounds S3 and S4, murmurs, arrhythmias, clicks, and rubs, and palpate for precordial heaves or thrills. Remember to assess capillary refill and check your femoral pulses for symmetry and any brachiofemoral delay.
Now, I want to draw your attention to cardiovascular exam. We don't do, speech language pathologists don't do a cardiovascular exam, but for some infants who are born before the lungs are mature, or they have inadequate development of oral structures for swallowing, or they were born with cardiac syndromes, syndromes that there's some defect of the heart, swallowing actually becomes a cardiovascular activity. So again, as speech language pathologists, we're responsible for understanding apnea, bradycardia, tachycardia. We have to understand respiratory rates and cardiovascular rates, because when we introduce feeding, it becomes a cardiovascular activity.
When assessing the respiratory system, look specifically for any signs of respiratory distress, such as expiratory grunting or moaning, nasal flaring.
So I'm stopping here because I want to remind us that when we swallow and breathe, that is a shared anatomy, and we have to make sure that food and fluids are going to the stomach and not to the airway. And I just mentioned just moments ago that feeding can become a cardiovascular activity. This nasal flaring that they're talking about here, I'm going to play it again and maybe even rewind it a bit, is one of the core symptoms or features that we look for as a speech language pathologist when we start feeding an infant. So we look at the baby in this state.
Nasal flaring.
See the little nostrils just get a little bit bigger there.
Retractions, which may be indicative of underlying surfactant deficiency.
And right here. So we look for these behavioral symptoms to indicate that the baby is really struggling as they're trying to take the bottle or the breast.
Asymmetry of the chest may suggest an underlying pneumothorax, especially if the infant received positive pressure ventilation in their delivery suite. Auscultate the lung fields, paying particular attention to any asymmetry in air entry and breath sounds, and any added sounds such as crackles.
I can't believe this little guy's sleeping through all
Our
this.
infant here has no signs of chest asymmetry, an immature breathing pattern, or respiratory distress. Examine the abdomen, assessing for
Okay,
dystension,
now I'm going to
bowel loops, or
fast forward just a little bit here to the neurological exam.
When performing the neurological exam, assess tone, movements, and reflexes for appropriateness for gestational age, and any
Tone, movement, and reflexes. So this is part of their neurological exam, and it's part of our behavioral observations before we start feeding an infant who's been referred to us for a swallowing disorder. The infants are born, I think I have a couple parents in the class, but infants are born with a set of what we call primitive reflexes. So they're reflexes that prepare the baby to feed and swallow. And they also have what we call tone, and tone is simply a word to refer to the readiness of the muscles to engage. And so these are healthy babies that you see here, but we're going to do a similar neurological exam on our babies before we start feeding, letting them feed.
expected asymmetry. Look for any tenderness, which may suggest smells to see if they are open, large or small, bulging or depressed. Assess for bulging or sutures or any evidence of caput. Cephalid hematoma or subgaleal hemorrhage. Check the red reflexes. Check for any signs suggestive of spina bifida occulta, such as hair tufts or sacral dimples. Also, don't forget to check the primitive reflexes, with some of these may still not be well manifested at 35 weeks gestation, as you can see here during the examination of our late preterm twins. The rooting reflex is elicited by stroking the infant's cheek. The infant should turn their head in the direction of touch and open their mouth in anticipation of feeding. This is minimal in our patient, as our infant has just fed.
Okay, so that was the rooting reflex. This is one of the things the speech-language pathologist is going to refer for. Please note, she said this baby has already eaten, so hunger is a neurological event as well. And so if the baby's satiated, it is going to depress that primitive reflex of the rooting reflex. But typical babies, younger, before 3 months of age, you can stroke like they show you in the video, and they'll turn their head pretty rapidly to the stimulus. And that's what we do. We check their sucking on what we call a non-nutritive suck. So before we give them some nutrition, like a bottle or something, we also use our fingers, put a little pinky finger in the baby's mouth and look for non-nutritive sucks for safety reasons. And I'm going to go back and show you this here. You can see the little guy's jaw moving nicely in this image here. I think I went just a little bit too far. Watch the jaw moving up and down. So usually you'll do 2 or 3 sucks before you get a swallow. And what you'll see in this one, this little infant here, is that he was suck, suck, breathe, suck, suck, swallow, breathe, suck, suck, swallow, breathe. And there, show you a couple other primitive reflexes we look at. There you go. Please tell your sister I'm recording. Mom's recording. Yeah, I want to point out here what you're seeing, how they swaddle the baby, and they keep the hands up by the baby's face, and the baby typically is tucked in a little bit better here, but this is called swaddling, and this is something that calms a baby, and I'm going to be talking about that a little bit more as we move forward. Okay, so you're welcome to watch that video as many times as you want to, but it's really helpful regarding what we do with infant feeding and swallowing. Let me see if I can find our PowerPoint here. Whoops, sorry about that. Pause here. All right, so what we want to consider, again, I'm going back to give you the details, that When we work with infants, the speech language pathologist approaches this problem in terms of the life of the infant is very different after birth than it is during the 9-month preceding birth, or a little bit less. But the big deal is infants are responsible for achieving their own physiological stability. When they were in utero, they were real comfortable floating around in the amniotic fluid. It was up to the mother to make sure that they were fed and took care of their body temperature. But this all rests or falls to the infants once they're born. And what we have to consider is that when babies are born, they have immature neurological systems. And the earlier, prior to full term, that babies are born, the more immature that neurological system is, and being able to achieve physiological stability is not always easy. And this becomes one of the most significant barriers for the baby when it comes to feeding and swallowing. What we were looking at here in terms of being able to feed and swallow is we need to have a developed respiratory system that's integrated with the cardiovascular system. And so in our field, we have to understand embryological development. And so what I've highlighted here for you is some of the key factors associated with lung development. For example, by day 4 of embryonic development, your first lung buds form, and the intestinal tract, or the gut. It's actually one of the most primitive aspects of the embryo. By 32 to 36 weeks of gestation, lungs look much more like the adult lungs, although they're not yet completely developed in terms of structure that they're going to function like adults do. Now, I'm giving you the second bullet, the 32 to 36 weeks, because that kind of information informs the speech language pathologist when they go to work with babies in terms of how old the baby is at the time of their birth, what's their gestational age, and that tells us what we can expect for lung development. All right, a couple of terms I'd like you to be familiar with as we move forward. NICU stands for Neonatal Intensive Care Unit. So typical full-term babies are either born at home with a midwife, or they go to the hospital and they're born in the regular OBGYN unit. In the case of our preemies, they need some extra medical attention or specialized nursing skill or physician skills, and so they go to the NICU, Neonatal Intensive Care Unit. It's sometimes called PICU, Pediatric Intensive Care Unit, with a neonatal component. Just depends on how big the hospital is. Gestational age is the time from the woman's last menstrual period to that point in time that you're calculating a gestational age. In the video that we just watched, they talked about oxygen saturation, how much oxygen is in the blood, and we can measure that. Bradycardia refers to an irregular heart or a fast heart rate. But more importantly is this last one here, which is states, and that's the one I really want you to take a note about. States refers to the baby's ability to achieve homeostasis, or a physiological state that doesn't tax the neurological system, doesn't tax the other organs in the body. And what we look for when we're doing pediatric feeding and swallowing is we're looking for babies who are able to maintain a homeostasis, or a state that enables them to feed in the most safe and efficient manner. A couple things, other things I want to talk about with our babies that we take into consideration is babies have the same structures as adults, but their proximity or the relationship to each other is very different. So when babies are born, you look at my first bullet here, when babies are born, they have a smaller mouth, but more importantly, in a full-term baby, the tongue fills up the mouth, and a full-term baby, if you ever have been around a brand new baby, if you pull their mouths open or put your finger in your mouth, you're going to say, wow, my finger's being touched in all areas. Above, it's going to be touched by the hard palate, which we learned about in an earlier lecture. The tongue's going to cup around your finger, and then on the sides, on the inside of the cheeks, they have these little fat pads or sucking pads, buccal pads that fill this oral space. And the function of the structural differences is that it enables the baby to express milk from the nipple. Because the tongue and these fat pads fill up the oral space, babies are obligate nose breathers, so they have to breathe through their nose. One of the other differences is the epiglottis, the piece of cartilage, one of our cartilages of the larynx, actually makes contact to the soft palate. So you have a shorter length of the vocal tract in young infants than you do in adults. And then I've put over here on the right-hand side the primitive reflexes that we're looking for that we saw in the video. And then finally, with babies, one of the things is we do pay attention to baby communication, and we know that moms are going to attach meaning to these primitive sounds that babies make. Brand new babies do not have any consonants. They primarily have a very small vowel-like repertoire, which is mostly producing sounds that are caught in the airstream due to what the mouth is doing. So they don't have a lot of volitional control to manipulate the tongue to make a certain sound. It's really all part of their physiological or biological functioning is where we get a lot of the sounds that babies make. Those cute little squeaks are because of that full oral cavity. Now, in a healthy baby, what we look for as a speech-language pathologist is we look for an easy initiation of sucking. We look for a rhythmical pattern, and in the video, it was kind of slow, but she said that baby had already eaten. But we look for that suck, suck, swallow, breathe, suck, suck, swallow, breathe, suck, suck, swallow, breathe. We know that young infants, the early babies we work with, are only going to drink 4 to 6 ounces in 20 minutes. That'll double when some time has passed. And the suck itself evolves as the neurological system matures. The suck evolves from an up-down movement of the tongue to a forward-back movement of the suckle. All right, and then another thing we need to know about babies that we're specially trained to look for are these behavioral signs. But it is typical for the brand new infant, even full-term ones, to choke or cough a little bit while they're swallowing until they get that coordination and get used to that nutritive sucking. That most of them have only engaged in non-nutritive sucking up to that problem. The two primary things we see in the babies that we work with are respiratory problems and also gastrointestinal problems. These guys often have a lot of difficulty with reflux, and so we have to keep a real close eye on those. Alright, now this video here, I played in my class this spring. It's a little disturbing, so I want to prepare you for that. But this is actually a video someone's family posted of a baby who has seizures that will cause respiration to cease. And so I wanted you to see what happens, what it looks like when a baby stops breathing. Whoops, I'm so sorry. Now, some of the things you can see is the color is changing. You're starting to see a blue color on this baby here. You're going to see some increased tone in the face and the neck region. And I think you even see a little bit of eyebrow furring right up here.
Hannah! Hannah! Come on, baby! Baby! Hannah! Hannah!
Big inhale. Okay, and then this other one here is a little guy. They posted a little preemie that's only 26 weeks old. And I did want you to see the difference in size from the healthy babies we looked at. You can see we don't have a lot of fat there. You can see the rib cage and the asymmetrical breathing that was going on. This is the pulse oximeter on his foot, measuring the air, and you can just see the baby's lack of movement. And I want you to notice all the noise. This is a baby in a NICU with all this medical care that's going on to keep this baby alive. And here you can see his little breathing, difficulty breathing, gasping up there. So there's some pretty significant differences between our healthy babies and our babies who are born premature. So one of the things we want to do is as we're trying to figure out how best to feed the baby, we're including the caregivers, the moms, in that option, because that's how they attach with their babies, is feeding them. There's just something so primitive and so basic or fundamental for a mom being able to feed their young baby. So we work on positioning. Now, if you think back to the very first, the healthy babies, at the end of the video, I referred your attention to the swaddling. That's a really nice position. However, if you think of the most recent baby, that little Noah I showed you, how do you put that baby without compromising their respiratory status into a physiologically appropriate position for feeding? And that's the job of the speech-language pathologist, to make sure that can happen. We also have, I'm going to go back to this state behavior. So our job, which takes much more than one lecture, our job is to figure out what we can do to help that baby achieve homeostasis. And in terms of swallowing, that homeostasis is going to be the link or the bridge for safe swallowing, for safe and efficient swallowing. So in many cases, we use that swaddling technique that you saw earlier in the video, especially if the baby's a little over-aroused. It helps them calm down. However, we also have to be careful if the baby's lethargic and sleepy. That's just going to put them into a deeper sleep, and that's not an optimum state for feeding. So we have to do some problem solving when we work with our babies. The other thing I had put a note here is we probably need to use skin-to-skin contact and reduce light when we can. Going back to Noah's environment in the NICU, it's noisy. People are touching him all the time. They do a good job of trying to keep the external temperature good for this child, but with all the movement and all the just aversive kinds of things that are going on with the medical treatment, that's really hard. So getting this child used to skin contact and giving them opportunities to attach to their caregiver becomes real important to the speech-language pathologist. Some of the things that we look for when we first start feeding, and you didn't have to learn these, I just wanted to share them with you, is of course we want the babies to be able to latch onto the breast or the bottle. And that rooting reflex that we saw earlier, that kind of gives us an indication whether the baby will or will not. There should be an immediate initiation of the suck. Our preemies do not or cannot do that. We look for audible gulping swallows. Early on, when a baby is not neurologically mature, you'll see a little bit, but it goes away pretty quickly. But our babies who have some significant disorders, it does not. We're going to look for milk loss. We're going to watch those eyes. We talked about the eyebrow furrowing or eyebrows widening or watering. Change of skin color. If they start flexing or arching their back is a sign that perhaps they might be respiratory compromised. And then we watch their oxygen saturation as well. So these are all, the speech-language pathologist who works with young children and infants for feeding, it is truly a behavioral observation and having the medical knowledge to know what to do. And we talked about some state behaviors.